which is a very important, as you know, very important aspect in understanding the pathology and performing all sorts of intervention on the aortic valve and the aortic root, whether it's surgical or it's transcatheter technology. So I think we'll skip through the first few slides and have more of a discussion about cases later on. So anatomy of the aortic root and the LVOT, I think, as I mentioned, has been clearly elaborated by my colleague in the last hour and a half. Any of you has question or concern or any comment about the anatomy, the aortic root, the LVOT?
No, from my side, no.
So this is a very, this slide shows a very common understanding of the aortic valve. You're all aware of it. You can name all of the structure, the planes, the points, all the pitfalls that we can encounter during surgery or transcatheter procedures. صح?
Yes, yes.
You're all familiar with this.
Yeah, there is some of the important structure either in surgery or in transcatheter in this structure, especially with the sutureless aortic valve and TAVI as well. Namely nadir, especially the nadir, and how to locate the nadir, especially now as Percy valve is going more and more, especially with minimally invasive, I believe.
Okay, so again, also the bicuspid valve variation can be named. This is a very common question in the exam. I think you should be familiar, should know it as your name. All the severe classification Mazen have mentioned.
Yeah.
You should be familiar with that. And also there are subcategory common nomenclature that you should be able to know as well and recognize, whether, for example, in type 1, whether it's left or right fusion, right or none, and left or none, left and none fusion. I think the common type is left and right fusion. Okay, so so Haitham, since you're here now, huh?
Yes.
Okay,
unfortunately, so really I wasn't there.
خلاص خلصتوا نجحتوا؟
yeah, لأنه re-accreditation of the program.
ايوه عارف جاكم دكتور تركي صح؟
Yes, ما شاء الله. You know everything.
طيب, how do you quantify aortic stenosis?
So the aortic stenosis, I will quantify it in mean of the imaging now. I will not speak about your question in mean of the imaging, not the history and physical examination and all that.
Yes.
So in mean of the imaging, the main things is the echo. That I need to see the echo. I need to see the valve area, 1. So in the severe, if you have a valve area of less than 1 and moderate is 1 to 1.5, then also I need to measure the gradient also in the echocardiography to know about the gradient. And sometimes also I need to know about the ejection fraction of the patient, especially in cases of low ejection fraction with a small area plus the gradient less than 40, which is indicates the severe, not moderate. I mean, more than 40 is severe. At that time, I need to interfere. I need to do dopamine stress echo to determine is it true aortic.
Step backward. So you said area, gradient. What else?
Area, gradient, and also the morphology of the valve itself, the burden of calcification of the valve, the restriction of the valve. This is also can give me a hint about the severity of the aortic stenosis. plus other things that pathology that lead to aortic stenosis. Is it rheumatic? Is it senile degenerative calcification that lead to this pathology?
Okay. And
This is
velocity.
the echo.
Velocity.
So area, gradient, pressure half time, and sometimes you can depend on calcium score.
Calcium score, this is with different modality, which
And
is CT
peak
scan,
velocity.
if you're in doubt.
Yeah, peak velocity, area, gradient, velocity. Half time is for AI, to quantify AI. And the burden of the calcium, most likely the calcium quantification, if you want numbers, it's by CT scans, not by echo. And
Yeah, by CT.
Yeah, so, okay, so that's good. We can quantify it mild, moderate, severe, as you can see in front of you in the slide. But in the guideline you've seen, and I'm sure you all know this now, is stages, A, B, C, and D, right? So you should be familiar with this. Although this is, I've never seen anyone use this staging, but it's in the guideline. You might have question in the either oral or written exam. So now let me ask you, Hussein, now you can tell us about low flow, low gradient, please. What do you know about it? How do you define it?
If patient presented with severe aortic stenosis as term of reduced valve area, but his gradient is not reaching more than or 40, and his ejection fraction is low. So we have to differentiate between the gradient, it's low because of the low ejection fraction, or there is no the gradient is low because there is no gradient to reach the severe.
Okay.
So in this patient, we can do a stress echo with dobutamine.
Mm-hmm.
If the area increase more than 1 and the gradient less than and the area same and the gradient increase more than 50, that's true stenosis. Of course, the ejection fraction will be increased by 20 at least. The area fixed and the gradient increase, that's mean true stenosis. If the area increase and the gradient is still low, that's mean it's heart failure and low ejection fraction, pseudostenosis. If the ejection fraction not increased more than 20 and still gradient borderline, we can do calcium scoring by CT. If it's more than 2000 in male or 1020 in female, that's mean true stenosis.
2000-ish.
I'm not sure.
What's the question?
The calcium score.
Calcium score.
Yes.
2000s, yes.
إيه بس هذا رقم
2000s. What's the unit? Okay, I don't know. Okay,
because there's two measurements in calcium score. There's the Hansfield unit اللي هي 2000 1200, and there's a cubic millimeter, which is I think there was no difference between male and female فيها, I'm not sure, but there's two, so you should know which one you're talking about. And it's all done on CT scan. It's used also for coronary calcium scoring, the Hansfield unit. Okay, so that's good. So what about so when you do dobutamine stress echo, you said there should be increase in ejection fraction.
No, not in ejection fraction, in stroke volume actually.
أيوة, stroke volume. So what is the number?
20
more
ml.
than 20%.
So what is the normal stroke volume for a person? Stroke volume index.
70.
70 ml.
stroke volume. يعني أنا ماني شايفك حسين بس there's a different stroke volume between male and female, big person, small person. So 70 is not a fixed number. Stroke volume indexed على body surface area. What's the number?
I'm not sure about the number, but it's affected by different, as you said, male and female, the heart rate and the ejection fraction.
Yeah, but if you index it, it's going to be a fixed number. If you index it على body surface area, it's going to be a fixed number, just like cardiac output and cardiac index.
I think it is 10 ml per kg, and this is why I think we said
I think it's
70.
1 ml per kg.
Huh?
Yes, sorry, 1 ml per kg. So we need to know the height and weight of each patient to calculate the index.
Yeah, I think 1 ml per kg in adult and 1.5 in pediatric.
No, my question is, what is the normal stroke volume index for any person? يعني في الإيكو في رقم. إذا كان أقل من كذا, then this is a small low stroke volume index. It might give you a falsely lower gradient. موجود قدامكم على السلايد. 35. شوف symptomatic.
Yes. I always read it. Yes.
Yeah. Okay, so stroke volume index less than 35 ml per meter square, so per body surface area, is considered low. So if you have a patient with low EF, okay, and you expect to have his stroke volume index less than 35. With the dobutamine stress echo, one of the numbers that you should see that the stroke volume index actually increased in response to the dobutamine. Okay.
Yes.
So what other scenarios or examples where you will see normal ejection fraction but low stroke volume index, which will give you low gradient maybe and underestimation of the
paradoxical low flow low index.
Paradoxical low flow low gradient.
هو paradoxical low flow AS. But where do you expect to see it clinically?
Myopathy patient. The problem in the muscles.
لا يعني انت ما عندك مشكله قصدك في الميوكارديوم؟
Yes.
والله اول مره سمعناها بس لا انت you have no problem with the myocardium. The EF is normal.
But the gradient is low.
But the gradient is low and the stroke volume is low. When you look at the echo report, you see
tachycardic patient.
Tachycardic. Maybe
hypertrophied patient, hypertrophied ventricle actually. So this is why, because of the small ventricle, this is why I have the low stroke volume, because no space for the preload to expand the heart. And this is this is the one. And sorry, I was wrong when I said about that paradoxical. No, it is with a different scenario. The information I mentioned, I was wrong.
This is the paradoxical low flow severe AS, usually seen with normal ejection fraction, طبعا, but usually seen in small lady with hypertension and severe aortic stenosis, or with aortic stenosis, obviously, but she will have small ventricle, hypertrophic, diastolic dysfunction. So you will see typically the stroke volume index is 25, 28, and those cases, even if there's no room for the dobutamine stress echo because the EF is already 60 or 70% sometimes, the calculated ejection fraction. So you can't really put them under the dobutamine stress echo. You're not going to get any information. So those patients we usually tend to
control the hypertension and reassess again.
Yeah, and no, I mean to assess the aortic stenosis, you usually do calcium scoring.
Yes.
Calcium scoring, okay. All right. So this is a famous graph for the natural history of aortic stenosis. You should have it in your mind. You should have it always. Also explain it very well to any patient you see who's going for surgery. Okay, because most of the patients will become mildly symptomatic or having some chest pain. But when you see them in the clinic or when you see them for surgery, they feel fine. So you need to justify your surgery, right? You need to justify your intervention for this patient. So what would you tell a patient coming for a severe aortic valve replacement, a 70-year-old male with having some, had a syncopal attack, for example, a month ago, one syncopal attack, and he will not have severe aortic stenosis. What are you going to tell?
You mean as a prognosis or mortality?
Ayub.
Yes. Syncopal attack, it's 2, 3, 1. Syncopal attack their survival will be around 3 years, and chest pain will be chest pain will be 3 years. Syncopal attack 3 years, and pain will be 5 years. Syncopal attack 3 years, and heart failure symptoms will be 2 years. And in general, at 5
ايش 2 year حسين؟ ايش 2 year؟ انا المريض قول لي بالعربي.
لما المريض يكون عنده اعراض، الدراسات بينت انه في ال5 سنوات الجايه 20% من المرضى اللي عندهم اعراض يكونون موجودين، و80% هيكون عندهم 80% هيكون عندهم وفاة أو مضاعفات.
هو جاي بشيست بين يا حسين، سو أنجنا المريض اللي بيسأل عنه دكتور سينكوبيال، سو فقد وعيه، فكم حتديه إذا ما سووا العملية يعيش كم سنة؟ 50% of them they will die in 2 years.
3 years.
3 years, yes. Syncopial attack.
أيوة. So 50% will die in 3 years. 50%. So this is a very compelling reason. طبعا it's very historical data. We don't do this anymore, and this is how you should approach severe AS. It's very common, very easy to understand. يعني لما تشرحها للمرضى, and I think it's you should always refer to this graph.
Yeah.
طيب.
Even now with a new trial that was just published for asymptomatic severe AS, which show the mortality benefits when you intervene. I think the guideline will be changed. I think so. What do you think, Dr. Fahd?
يلا دحين the guidelines. So what are the guidelines for aortic valve replacement in severe AS?
تفضل حسين. طيب
كلاس
severe aortic.
تفضل I will mute.
يلا هيثم.
طيب okay, for severe aortic stenosis you have a class 1 indication. First, if patient symptomatic plus severe aortic stenosis as we defined. If you have asymptomatic patient with a dropping in ejection fraction, this is also class 1 indication. Class 1 indication also severe aortic stenosis going for other cardiac surgery, CABG or mitral on the same setting. Then we have a class 2A indication, which is moderate aortic stenosis going for other cardiac surgery.
Okay. What about severe? Class 2 for severe aortic stenosis.
Class 2 for severe aortic stenosis if the 2A if the patient is asymptomatic with normal ejection fraction, but with a high risk.
And also severe critical stenosis, area more than 0.6, and if patient going class for severe area more than 6, if the progression of disease it's fast, more than 0.5 increase in per year. And there's one more.
في الستريس تيست صح؟
2A, yes. Cannot tolerate dropping fall in blood pressure after decreasing in exercise, stress testing.
ايوه بس unlikely يعني sometimes patient with severe aortic stenosis it's very dangerous to stress them or to put them on stress. So الصراحة أنا I rarely see this indication. Okay, so you were talking about asymptomatic AS and now there's benefit from intervening. Do you understand where is this coming from and why is it might be changing now?
Because they did a trial with a patient with that their valve area, severe aortic stenosis with a valve area less than 1 and asymptomatic, and they divide them in 2 groups, and they found that there is no increase in morbidity or mortality in compared to both groups. And I mean there is improved mortality and morbidity when they intervene earlier on those patients. The patient was a surgical AVR, not TAVI, not TAVR or TAVI with them. It was published 2019 or 20, I'm not sure, but recently.
بس ما كانت randomized كان؟ ما كان randomized.
No, randomized control trial. Well, I read it maybe 1 month back. I will bring it again. I have it. I will bring it again. Maybe I'm wrong because 1 month back I read it, but they randomized them. And it was published this year in New England of Journal. Just 1 second. Unfortunately, I didn't review it again. Okay. Hussein, you remember this trial? I sent it in the group before.
No, I'm sorry.
طيب, so it's coming. It's coming. The explanation of this also with all of the advancement in the surgical technique and the transcatheter technique is that the risk of the intervention is lower compared with watchful waiting. So that's what all these trials wants to prove. I'm not aware of the trial that was published, Haytham mentioned, but I do believe that nowadays it's gonna probably change in the near future, especially with the intervention of TAVR, with the introduction of TAVR. Sorry. Okay, so AI, I think Dr. Mazen have...
Yeah, Doctor, if you allow me, it was published in 2019. So there is a 2 group of patients were randomized, assigned 145, asymptomatic patient with very severe aortic stenosis, the valve area less than 0.75, with either jet velocity more than 4.5 or gradient 50. And they follow them 30 days, then 1 year. And they found that as a conclusion, just to cut it, they call recovery trial. Yes, recovery trial, the name. Asymptomatic patient with very severe aortic stenosis, the incidence of composite operative mortality or death from cardiovascular causes during follow-up was significantly lower among those who underwent early aortic valve replacement than among those who receive conservative care, which is the common practice right now in the guideline.
ارسلها في الجروب والله.
Yeah, I just sent it. It's a recovery trial. Then they published 1 year, which is also, I think, confirmed the...
Okay. So about AI, we also need to know the guideline for AI. We're not going to go in more details about it. I think Dr. Manzin have mentioned enough. So anyone can maybe Hussein?
Symptomatic class 1 symptomatic patient going for other cardiac surgery and low ejection fraction. Class 2A and B, it's dealing with the sizes of the, if it's dilated ventricle, if it's left ventricular end systolic diameter less than 55, that's class 2A. If and left ventricular end diastolic diameter less than 65 to 70, that's class 2B. And,
more than.
More than. Or patient going for other cardiac surgery, class 2A.
طيب, those are for chronic AI, صح? Because usually acute does not dilate. Patient will become symptomatic right away, most likely, and unstable.
Yes.
بعد إذنكم دقيقة بس.
طيب.
ألو. أيوة معلش.
تفضل.
So we were talking about the AI. You should also know about the quantification of AI, pressure half time, the jet width. It's all in the guideline. It's not very well known to us, but I think we have to know at least the numbers. In real life, the quantification of AI, I think, is not very easy, to be honest. You have to discuss it with a very experienced echocardiographer. Sometimes transthoracic echo is not enough. You may need to do a transesophageal echo to get full information. Okay, so we talked about the guideline for aortic valve replacement in patient with severe with aortic regurgitation. All right, so let's talk about some technical aspect of aortic valve replacement now. Maybe حسين, في عثمان, صح عثمان؟
في عثمان وفي بيان، في فيصل، وأنا وحسين.
طيب, يعني other than هيثم وحسين, anyone wants to يعني describe for us aortic valve replacement, maybe the steps from opening the aorta to implanting the valve? ولا مش موجودين الشباب؟
Okay, so aortic valve replacement, for me, I will take the patient to the OR. If the anatomy is, or the cause of the indication for AVR was aortic stenosis, especially the critical one.
Aortic stenosis, حتفتح الأورتا دحين خلاص, skip everything. أنت حتفتح الأورتا. Yeah, okay, where are you going to open?
So I will open a 2 centimeter above sinotubular junction. Then I will go towards the non-coronary cusp to have a better exposure for me to open the aorta towards the non-coronary cusp. Then I will take, after that, 3 suture in each commissure, Prolene 4O suture in each commissure to open the aortic valve in front of me for exposure. After that, I will start to take the leaflet out, starting from maybe the left with the myo scissor, and I need to be careful just to be on the annulus. I don't need to go further to cause a perforation, or especially towards the site of non-coronary, towards the left atrium, or to go towards the RV. After I took all the leaflet and doing debridement very carefully, there is one method also that I will use, which is I need my assistant to be with a sucker, metal tip, metal sucker without the tip, take it out, and just to take all the debris that for decalcification. This is one. And if there is a lot of calcification, I will use the nadir. The most important things that I need to have a clean area for decalcification to put my suture. After finishing, I will irrigate. I will stop. If I have the LV vent, I will ask the perfusionist, especially in the area when I'm doing the decalcification, the perfusionist to stop the LV vent. I don't want any of the calcium to go. Then I will with the normal slide irrigate. After that, I will size the valve just to be sure what's the size that I want to do. Then I will ask them to, after sizing, proper sizing of the valve, I will start to put the suture. I will use bridgeted suture. The most important things when I'm doing my suture is, and I will do it from the ventricular side to the aortic side. So supraannular, I will use a supraannular position to put the valve in supraannular position, which is almost currently all kind of valves, they are designed to be supraannular. Then the most important things, especially when I use the bridgeted, that I need to be, each suture need to be adjacent to each one. I don't need any space between them, just 1 millimeter or even just close to it, because I want to prevent any the idea is not to have a paravalvular leak. The most important area also when I'm doing my suture, I need to be cautious when I'm taking my suture all around the valve, but the area that lies in between the none and the right, which is the membranous septum, at that area I need to be sure, because I don't want to cause destruction for the conduction system. After finishing all my suture, I will resize again just to be sure. Then I will put the valve. One of the important also tricks, especially if I'm using the cornet before tying, before the tying, that I learned from one of the consultants, just to move the suture, because sometimes with the cornet, if I took it and put it, it can be a little bit what they call it, not tight, so that can lead to infection or paravalvular leak. Because when I tie with my hand, the ethibond that I use, it's actually have a recoil that can this problem will not happen, but with the core valve, theoretically it happened. And then after I put the valve, I will test the valve. If it is mechanical valve, I will test the leaflet. No destruction of the leaflet or anything. If it's a tissue valve, also I need to look on it, just test it quickly that I didn't cause any perforation with my suture on the leaflet. Then I will close the aortotomy. طبعا, of course, I'm just talking about technical issue. However, on the same time of doing AVR, I need to put on my mind the time to protect the heart, give cardioplegia, either through the coronary or.
خلاص. Now, just the AVR aspect. So when you choose the size, what's in your mind? يعني until you put the size, so you size based on the size, that depends on your prosthesis. But what else do you think? And what factor is going to affect your size other than the annulus?
Yeah, the most important things, it is to avoid patient prosthesis mismatch. This need to be in my mind, and who's I'm operating on. يعني I need, before I'm going in, to see. طبعا, to be honest, يعني before going to the AVR, I need, in the echo, I need to size the annulus. Then I will see the body surface area, the valve I will use. I have high profile valve, low profile valve. The tissue valve, consider high profile valve. Even when we say, for example, 21, this is corresponding to the valve itself from the sewing ring, not the effective orifice area of the valve. Mechanical valve having less, having a better effective orifice area than the biological valve. So if I'm concerning, or this patient, for example, is 40 years with like 100 kg, 190 or 180 height, that means he needs a bigger valve, not either tissue or even the mechanical. And I need to calculate before going to the OR. I will calculate the body, the effective orifice area of the valve that I will choose, divided by his body surface area, to be sure that the ratio that will come, it's not 0.8, that consider as severe patient prosthesis mismatch. طبعا solution I have to overcome this, if I'm facing, let's say, a patient that I know we will end up with patient prosthesis mismatch, either I will choose low profile valve, depend on the other characteristic.
Okay. We'll talk about a couple of slides. Okay, so that's very good. Why would you use cornet?
No, because I think in my center, they use it like with all cases. But I work with different consultants in other places. They tie with without the cornet. I know the cornet, to be honest, it's supposed to go with minimally invasive for better access.
Yeah.
But
بس حتى ال AVR they use cornet for AVR.
Yes.
Really?
Some consultants, they have concern about using for AVR.
Yeah. So anyone has experience with cornet and AVR in other center?
Hussein, what they do with you? I mean, in I think
for aortic
University
valve,
hospital.
We use it for mitral, but for aortic valve, I think they have concern to use it.
Yeah.
We don't have it here in the map.
أيوة. We don't have it, man.
We don't have it. They brought maybe one set, used once, and then I did not see it again.
Yeah. غالي لأنه.
Yeah, it's expensive.
إيه الرياض عندهم فلوس.
I think the valve is the space. I've never used it, to be honest, in aortic valve, but I'm always I wonder how is spacing become, because sometimes it's very difficult to type with your finger, especially in tight space. I've never used it in aortic valve. Anyhow,
sometimes, especially in the AVR, when they come in the area of of the left and main coronary, they don't use it. Those both area they tie with their hand, and with the other valve they continue with the cornet. But of course, one of the pitfall, I need to check the coronary before going on, and before closing the orthotomy. I just remember I need to check the both coronary. I need to see it. I didn't close it. But the orientation, because I was speaking in general, if I'm doing AVR, the orientation of the valve, the struts, I don't need to end up that I'm putting struts in the wrong way. Then I will end up with myocardial ischemia because I close left main and right coronary ostium.
Yeah.
This is one of the most important pitfall that can happen with the AVR.
Good. Also with mechanical valves, you have to consider, or with any valve that has a higher profile sometimes, or a valve that goes into the LVOT, you have to consider the size of the left ventricle outflow tract and make sure that the valve is going to fit well. Some valve, as I mentioned, especially mechanical valve, has some extension into the LVOT, like the Onyx, the new Onyx valve has an extension scaled down to the LVOT. So if there is calcification in the LVOT or hypertrophied septum, it might be challenging to actually position the valve and have a good result. So all of these pitfalls have to be considered. So again, when you think about the anatomy, it's all this. It's not only measuring the annulus. It's also, sometimes you will have difficulties with the sinotubular junction. It might be tight. So you have to consider that. You may implant the valve, but then you can't tie it, or you can actually tear the aorta, trying to position the valve in place. All of these factors should be considered. Some surgeon will do pledgeted or non-pledgeted suture. Some surgeon will do a continuous suture. So there are many techniques that can be used to suture the valve in place. The advantage of using continuous or non-pledged suture is that you decrease the material in the LVOT, and hopefully you get a better hemodynamics. So especially in small annuli, if you have a lot of material, you'll decrease the effective orifice area even further. Okay, so patient prosthesis mismatch. Uthman, maybe you can help us with the definition of patient prosthesis mismatch.
Definition of patient prosthesis mismatch with when the valve area is it produces a gradient that is smaller than the body surface area that needed for the patient. So it is a mismatch between the size of the body surface area and the valve area that needed to be implanted for him.
Yes. So how do we measure it?
Effective orifice area.
How effective orifice area?
Effective orifice area of what? Of the valve, of the prosthesis.
Yes.
Yes.
Right.
Divided by body surface area, and so if it is less than 0.65, it will be severe. If it is more than 0.85, it will be mild.
Yeah. So patient prosthesis mismatch, it's less than 85. Effective index effective orifice area is moderate, less than 65 severe. Patient prosthesis mismatch. So how do you avoid that?
Avoiding putting a small valve. Usually you don't put a 19 valve. So you go
how do you know that 19 is small for this patient on the table?
Body surface area. There's a chart comes with the valve that shows you the green is what is good for the بيان. أهلا دكتور.
Okay.
There's a chart comes with each valve. It shows you which valve is suitable for the body surface area of the patient. Yes,
so that's right. So before you implant the valve, you have to know the chart. Usually it's available in the OR. If it's not available, you can look it up. It's available online. So before you go in, you know the body surface area of the patient. If you have concern, then you should. So by definition, you have a small aortic root. This patient have a small aortic root. If you're going to replace the valve, you will have issue unless you deal with it, right? So if on the chart, if it's usually it's green, yellow, or red. If it's yellow or red, then you will have issue with the patient prosthesis mismatch, and you will most likely need to do something more than just aortic valve replacement. طبعا it depends on the patient. If it's elderly patient who's not active, then you can use your judgment at that time. Okay, excellent. So, all right. So, Bayan.
Hello.
طيب, so what are the options if you have a lady who is let's say 65, active,
Okay.
with a small aortic root? She's on your table for aortic valve replacement, and she has small aortic root. So she's let's say body weight is 75 kilogram, height 165. And her root is only 19 on the echo. So what are the options that runs in your mind before you go in?
Either aortic root enlargement, or using a sutureless valve, or using a valve with a better effective orifice area, like a mechanical valve, is better than bioprosthetic.
Okay, so mechanical valve, sutureless valve,
aortic root enlargement.
إيش كمان? There's two more options.
There, you can tilt the valve. You can put the valve tilted, or even put the suture from outside, from the non-coronary area, just to reduce the sutures. So it might help. Or accepting the patient prosthesis mismatch, giving the patient age, but she's active, so it's better to do something about it.
Okay, what other prostheses you can use?
TAVI?
No, stentless.
What do you mean? Stentless. But that's going to be a major surgery for a patient with her age.
Yeah.
And it's more difficult.
No, exactly. Stentless or bental, aortic root, changing everything to...
that's more okay. It's an option. It's true.
Or you have experience and in luxury hospital, you can do homograft.
Yeah. So you're all right. So the options: aortic root enlargement, mechanical valve is better, stentless valve, sutureless valve, or root replacement. So it depends on the case, but this is usually the typical answer for small aortic root option, right? So Hussein, can you tell me what options of aortic root enlargement procedure we have?
Mainly we have three. In adult, we can use the Makhdom between the left and the nun, and cono in the middle of the nun.
Cono? Wait.
Sorry, neck in the middle of the nun, and cono between the right and the left. But actually, it's to the right to. It's near to the right coronary. Right coronary. It's not exactly in between the right and left. And there is one it's less commonly used. It's I think his name Wood. It's exactly on the what?
Oh no. Yes. Continue.
It's exactly between the right and left.
طيب, when you do a Makhdom, you said you between the left and the non-coronary.
Yes.
Where do you extend your incision?
To the anterior mitral leaflet, but not to exceed 1/3 of the anterior mitral leaflet.
Okay. So how much do you expect? What size do you expect to go up? How many sizes?
And the best one will be on the, but it's not used in adult, mainly in pediatric, the cono. And Makhdom, it will increase the size by 1 or 2, and neck it will increase by 1.
By 2, and there is no nays in between. It's the same Manogian, but you don't go more advanced with when you
Yeah,
go
but
to the anterior mitral leaflet. The same as Manogian, but they call it.
Manogian will give you more
Yeah,
space.
Yes.
Yeah. طيب, why Kono is only for pediatric? And you cannot do it for adults?
You can do it if you have experience. You can do it, but they use it because they want larger area. But you can do it for adult if you have experience.
Yeah, the issue because you open through the RVOT actually. So the RVOT, when you open it, there is also, they call it modified Kono. And the reason why they go for modified Kono, because you know that, Hussein, because as much as you go in the RVOT, the risk of arrhythmia and RV dysfunction will be more, and especially the coronary injury for the septal arteries also in that area, it can happen. So this is why they came up with a modified Kono. Maybe you saw it, even modified Kono. I don't know, Hussein.
Yeah, it's called Kono Rastan.
Yeah, you saw it, I think, with Dr. Zuhair, I think.
Okay. So, you all, so we covered this small root, I think. It's a typical question, a common question in exam or in oral as well. So you should be very familiar with it. Okay, so when you talk about a patient who's coming for aortic valve replacement, again, that 70-year-old patient that we talked about earlier, you convince him that he needs aortic valve replacement, and then you talk to him about options of prostheses, right? Mechanical versus biological valve. What do you have to tell him?
So actually, if he's 70-year-old, there is nothing called zero for structural valve deterioration in the aortic. We have mechanical valve and tissue valve. I will speak about tissue valve. When you have a patient with a 70-year-old, it's really in 15 years, you can say like 5%, but in patient with his age is 50, so the risk of deterioration, it's like 20 to 30% over 15 years. Mechanical valve is different than the tissue valve, but they will come with another profile of complication, which is the valve thrombosis. But usually they designed to be free of structural valve deterioration, but the pannus formation can happen on the sewing ring of the mechanical. But roughly you can, if patient with a 50 years old, 20% to 30%, 60-year-old, like 15% over 15 years, 70-year, 5%. And this is from what I conclude from different.
Yeah, I think you're right. In general, I think patients who are in their 60s to 70, 15-year freedom from structural valve deterioration is around 5 to 12% in the recent publication. But my question will next is, what is actually structural valve degeneration? How is it defined in those literature? And where did those numbers come from? So so you can understand, I think historically in the older surgical literature, it was defined as freedom from surgery. Okay, so yes. Any patient who did not have any redo surgery, it means that the patient did not have structural valve degeneration, and this is theoretically not necessarily true. Okay, so what is the definition of structural valve degeneration, or the new definition? You have to have valve dysfunction, right? Yes. Intrinsic valve dysfunction. So it's not paravalvular leak, right? And it's not endocarditis, and it's not patient prosthesis mismatch. So we have to have a clear separation lines between those 3 or 4 conditions. Structural valve degeneration is usually a problem with intrinsic problem with the leaflet, whether it's mechanical or whether it's stentless or stented prosthesis, or sutureless or transcatheter prosthesis. So all kinds of biological prosthesis now can have structural valve degeneration. It can be presented as aortic regurg or stenosis or combined, right? It can be due to thickening, retraction, disruption of the leaflet, and it's mainly going to be diagnosed with echocardiogram. So those definitions are now more common in the literature. And these are recent suggested staging for structural valve degeneration. I think you should be aware of this at the moment, but I expect that this will be used in the literature in the near future, more common, and you will be faced with it. So whether we have stage 0 to stage 3 and when to intervene in each of them. All right, so special cases for aortic valve replacement. If you have a patient with or dependent on hemodialysis, not a candidate for transplant, which valve usually you will, biological or mechanical?
Biological.
ليش؟
The prognosis and the life expectancy for this patient group, it's short, and to avoid the complication of the anticoagulation with the multiple brick during the hemodialysis. Their average life, it's between less than five years.
But do you know the rate of valve degeneration with hemodialysis?
It's very high.
It's very high.
Recent literature, just I think very recent. They found actually they use both of them. There is no difference. Then a recent one showing that mechanical valve, it's actually better for them, especially if they are young. And if they are young, they will live more because the tissue valve will degenerate more with them. And okay, they are in hemodialysis, but think they will be a candidate for transplant. So you need something for them to live more. And just
he's not candidate. He's not candidate for transplant.
Not cardiac transplant, kidney transplant.
Why you will do cardiac transplant for patient?
I'm not saying cardiac transplant. Kidney transplant.
Yeah, he's not candidate for kidney transplant.
Okay, but
and
if
the
he's young,
and Dr. Fahd question, patient not candidate for kidney transplant. That's right, Dr. Fahd.
Sorry.
Yeah.
Okay, no, okay. So yeah. I will actually no difference between both, but more bleeding with the mechanical, but I will go toward tissue valve myself.
Yeah, but I think you have to explain again. This discussion has to come up with the patient. Depends on the patient situation, his age, candidacy for transplant versus no transplant, availability of transplant. But we all should be aware that the rate of degeneration for biological valve with those patients is very high. But anyhow, most of those patients now, very high risk hemodialysis patients, who will have transplant, who will not have transplant usually have TAVI. So okay. So
in the exam, what for the purpose of the exam?
For the purpose of the exam, I think if you have this discussion, what we just have, just so that you understand, okay, because there's no right answer, right?
Yeah,
even
because
the
even
guideline.
recent 2020 they publish this paper. I can send it even in the group يعني.
Yeah. So if you have, أنا بقول لك if you have the same discussion, there's no right answer. يعني ما تقدر تقول أنت غلط حطيت mechanical ولا أنت غلط حطيت biological valve. Okay, so there's no contraindication.
Okay.
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 So this applies for so many topics and for so many questions. Very rarely that you will have يعني a clear solid answer. يعني حتى في now if you have a question about aortic root valve sparing, whether you do remodeling or reimplantation, or there's preference, there's what you're comfortable with. It's unlikely, there's no clear solid answer, let's say. Okay, so you just have to show that you know your material and you're going to be safe. You discuss always with the patient, you discuss with senior colleague, you discuss among heart team. This is all what they're يعني I think this is what's important to show during oral exam at least. Okay,
can
so
I ask something because Dr. Fahd, I don't know, because you bring the issue of remodeling. Unfortunately, I wasn't remodeling in the aortic root, and I don't know if Dr. Mazen still with us. I just saw him. Okay, I think he just left. I think so.
Yeah, he left.
No, because there is a question in my mind. Okay, a question in my mind, especially in the remodeling. We know that they are there is a recent multiple publication to use external ring to stabilize the annulus with Yaqub, and that showing good result. And what is your thinking about this?
Haytham, I'm sorry, but it's explained in detail, and now they call this procedure AVR procedure. See the previous lecture, he's explained in a very good way.
خلاص.
For half
sorry,
an
Dr.
hour.
Fahd. Sorry.
No problem. طيب pregnant lady or not pregnant lady عفوا pregnant age bearing I think.
Okay.
I will go with
age.
childbearing tissue valve, except for very small percentage if the patient insists to have mechanical, and she will be very compliant for the plan of the controlling the anticoag during pregnancy.
Okay.
Yeah,
It showed so general rule, most 99 of the patient, I will go with the tissue valve.
ليش؟
Unless she is, because of the heterogeneity of the warfarin, and I cannot sure the heterogeneity is more than 5 milligram with warfarin, but I don't know how much you will require.
Okay.
If she is highly educated and she insists to have mechanical valve, there is no contraindication. During the first trimester, we can manage her with warfarin less than 5. If it's more than 5, we have to give her enoxaparin, and she should measure the factor 10 Q6 hours from the dose of enoxaparin for the first trimester, and the risk of heterogeneity will be low in the second and third trimester. And during delivery, we can manage this as planned procedure. Where we admit her in the hospital, we stop the warfarin and start her on heparin infusion, and stop that before when she complain of pain for delivery.
Okay, so it's all mentioned the guideline as you as Hussein just stated. The guideline for managing anticoagulation during pregnancy, it's doable, effective, and somehow safe. But again, so you have to discuss it with the patient. That's all of the time feasible. There's risk for heterogeneity. So you have to consider all these. One more point you have to add to the discussion is that the risk of redo AVR. Okay, so aortic valve replacement, you will replace again in another 5 to 7 years. What's the risk of doing another redo AVR? Or what is the risk of redoing the intervention, whether AVR or TAVI, depends on the age and the preference of the patient. So this you have to add to the discussion with the patient as well. Okay, so non-compliant, drug addict, high risk of bleeding. Obviously, all of these are special cases you have to consider again in selecting between biological versus mechanical valve. Okay, so I think we can switch gears somehow now to, we just take few slides about transcatheter, about TAVI, and then we can discuss a couple of cases and talk about aneurysm and dissection quickly. All right, so for sake of the exam, obviously the trials you have to know, partner 1, 2, and 3, core valve, US pivotal trial, TAVI, and low-risk trial, or published. And I think you've come across them most likely, صح?
Yes.
Okay, so what prostheses you guys are aware of in transcatheter world? يعني ايش الفالف
core valve
ايوه
and evolute. Yeah, these two.
Core valve is evolute.
Yes, it is the same from Medtronic. Evolute, the core valve, evolute are Sebian. That's it.
Sebian.
أيوة.
Sebian.
Yeah, so that's it. So evolute R is the latest core valve في دحين pro بس Medtronic and Edward. Okay, Sebian is Edward is 3. في اللي دحين في السعودية كمان accurate new هذا اللي في النص.
I see.
It's been used يعني couple of times. It's from Boston Scientific. So it's but you should when you have this question you should say either balloon expandable valve or self-expandable valve. Okay, so those are the main category, and then self-expandable is evolute R or Medtronic core valve evolute R, and balloon the expandable is the Edward Sapien 3 or Sapien 3 Ultra. No. Okay, so those are the pitfall for TAVI. Okay, it's been very obvious when you read the literature. I suggest that you read يعني مثلا partner تمسك partner 1 AB and you read it with the US pivotal trial and you compare it. This one let's say generation of valve. بعدين the intermediate risk, which is partner 2, and the TAVI is another generation of valve, another era, and then the latest low risk and partner 3 trial is the latest where they use the latest generation and the latest era for TAVI. You will notice that paravalvular regurgitation was a big deal and very common in the first generation. The presence of paravalvular regurgitation more than mild was associated with mortality, with a longer intermediate or long-term mortality. So this was the Achilles heel, let's say, for TAVI back in the days. Now you will notice again in the literature that paravalvular regurgitation incidents have decreased dramatically. So you will not see anything more than 2 or 1 to 2% incidence of more than mild paravalvular regurgitation, moderate to severe, with the new generation. The reason is the technology has improved, the experience of the implanter has improved, the introduction of CT scan after the first generation have the make the implanter understand more, avoid pitfall during implants, and also patient selection. So it's very important and mitigate the paravalvular regurgitation. So you'll see here, this is the slide. I think this is, yeah. So as you can see in the third generation here, more than moderate or more is 0 to 1.3 in the latest literature, compared to 12 and 9% in the earlier publication. This slide shows almost the same idea. So you'll see that with the evolution of technology here, this was the first core valve, the first generation of the core valve, compared to the Evolute Pro, which is the latest generation. You see no severe AI. The incidence of mild has decreased, and the incidence of moderate to severe also has decreased. The other complication with TAVI is heart block. As we understand and discussed earlier from anatomy, the conduction system runs between the right and the non-coronary system in the non-coronary sinus or commissure in the membranous symptoms. And usually during surgical aortic valve replacement, we take very superficial or pay a lot of attention during the bites in this area, not to disturb the conduction system. But during TAVI implant, usually this is unavoidable. We have to come across this the imaginary line here, the basal ring or the annulus, as we all call it. Okay, so the prosthesis has to come at least touching this line. So you have all this triangle between the right and the non-coronary has interference from the prosthesis.
Dr. Fahd?
Yeah.
It's the cause. It's obvious when we implant the valve, but how you explain the new heart block over years of implantation? And the literature showed it's still increasing comparing to the surgical group.
Yeah. So because of this valve, the Medtronic core valve, if you compare in the literature in detail, you will see that self-expandable valve has more incidence of heart block than balloon expandable.
Yes.
This is due to the radial force. The radial force of this metal, okay, which is titanium, is more than the radial force that the balloon expandable valve has. So the pressure that is applied, I think, continue to increase with time, right? So this is specifically true during the first 24 to like in the short term, because even aortic regurgitation, paravalvular leak during implant will be more than the subsequent days, because the pressure, the radial force that's applied from the stent keep increasing, and the valve compared to the shape of the annulus. I think this will explain the decrease of paravalvular leak and the increased incidence of heart block.
Nothing to do of keeping the valve, because in TAVI we are not removing the calcium and the valve, so it will not progress of disease will cause more heart block over 2 years or 3 years after TAVI.
Maybe, I don't know, maybe.
Yeah,
but
well, actually,
for at least the short term, the obvious explanation is the radial force for sure. Long term, what you're talking about, you may have a point. To be honest, I can't answer it.
Because they asked me this question in my presentation for the CBD, so I don't know the typical answer for that.
Okay, Hussein, and I read about this specific topic. So the one is radial force. This is the key answer, as Dr. Dr. Fahd answered. And the other thing, the risk factor. Yani why some of them they will develop, because if they have preoperatively any kind of left or right bundle branch block, and you see the picture Dr. Fahd he brought, if you have a calcium at the area around the membranous septum, burden of calcium high there, you have high chance during implantation and there's a follow-up. And this is what they showing.
No, the question they asked me, in some trial, it showed still after 5 years, still there is significant difference between heart block between TAVI and surgical group. No, it's increasing, so it's not related to the initial procedure. Why these patients after 5 years have more heart block than the surgical group?
Yeah, this is the reason. The calcium is there, radial force initially, fibrosis at that area, and if you go to look for their profile, you find more calcium burden, especially at the area around the membranous septum. And the area is under investigation. Yani if I will answer this way, and the area is still under investigation, and the data is emerging every day. This is what I would answer. يعني.
اللي سألوك جراحين ولا intervention؟
لا جراحين. Of course جراحين يعني إنه بكل الأسئلة كانت to show the surgical group is better.
You see in front of you now that this shows the incidence of actually heart block. So did not change a lot, okay, with the advance in technology, especially actually for sapien valve, it increased. If you notice in partner trial, the heart block has increased for the conduction complication. And this is due to the addition of the skirt here at the bottom of the valve to decrease paravalvular leak, right? So this increased the interaction between the valve and the membranous septums, which led to increased incidence of heart block or pacemaker dependency. You see here is 3.8 in partner 1, up to 10%, I think, was published in partner 3. All right, so neurological complication, again, surprisingly, it doesn't occur a lot with transcatheter technology, and it's still a major issue with surgery. So it's the Achilles heel for AVR in the recent publication is stroke, where in TAVI, the incidence of major stroke is actually statistically less than aortic valve replacement, surgical aortic valve replacement. This was not true at the beginning of the experience as well. In partner 1 and initial US core valve trial, the incidence of neurological complication was higher with TAVI. But now with the improvement in technology, decrease in the size of device, plus avoidance of ballooning or pre and post ballooning, this has decreased the incidence of interaction and calcium flying to the brain. So when you do your surgery, you have to think about this. And the stroke incidence of 2% with the aortic valve replacement is very high. When you do any aortic valve replacement surgically, you have to think about this. Do everything possible to make this as less as you can for patient and for the procedure itself. So you can see here, the incidence has decreased with time. Vascular complication was a significant issue at the beginning as well. But again, because of the delivery catheter that is smaller, increased experience of the implanter, patient selection, availability of alternative access other than apical access, all this has led to less reported vascular complication. We rarely see any fatal complication nowadays from transfemoral procedure. Other options, other alternative than transfemoral access, which is more than 90% of the TAVI now is done transfemorally. We have transapical falling out of favor nowadays because of the availability of other access. You can do transaortic access, a direct aortic through a right or a mini thoracotomy or a partial hemisternotomy. You can do subclavian access. You can do carotid access, innominate. Again, innominate, most likely you need to do a partial sternotomy, or some people does it above with an incision just above the sternum. And then there is the transcable access as well, but not very common yet. So all these drawbacks, let's say, of TAVI, paravalvular leak, neurological complication, vascular complication, heart blocks, is not the hot topic anymore, because most of them has been overcome, except maybe the heart block. Now they're the talk or the hot topics in the literature is about durability of the valve. Okay, so now we're going to low risk patients. They're talking about the leaflet itself, how durable it is, and the issue of valve thrombosis as well. So in the recent trial, there has been a sub-study for valve thrombosis comparing surgical and a transcatheter valve. Excuse me, let me take just a phone call. Durability, as we mentioned, and valve thrombosis. So when you read the literature, when you read partner 3 and the low risk trial, there are sub-study comparing surgical and transcatheter valve, looking at valve thrombosis. It's been an issue. Now there is no clinical, let's say, manifestation or significant clinical manifestation proven yet, but it's proven that thrombosis happen with TAVI more than surgical aortic valve replacement.
I think, Dr. Fahd, the incidence of TIA was more and it was significant, but it's not reflecting stroke. Which subclinical valve thrombosis?
Yeah. You're right. There was association of TIA more, but not major stroke or significant neurological outcome.
So do you think starting this patient on anticoag will help?
As you know, in the guideline, anticoagulation for bioprostheses is class 2B, I think.
Yeah, just for 3 months.
For 3 months. There has, people were shying away from it because there was some study came out after the guideline that shows there's no difference. And now with the valve thrombosis data that came back, most of the surgeons, well, at least some surgeons have went back to anticoagulation. There's no strong data, to be honest. There is more. There's data came out recently for actually double antiplatelet versus single antiplatelet for TAVI. That showed no difference. So more complication with double antiplatelet, especially with those older patients who has multiple medication that they're on, amenable for fall. So there's no clear answer in the literature yet. We don't know.
But in the guideline, still we have to start aspirin and Blavix for at least 1 year, right?
For the TAVI?
For the TAVI.
No, in the there's no guideline for this. There's consensus. There's consensus, aspirin, Plavix, based on what's done in the trial, okay? But ما في evidence. There's no evidence. The only recent trial that came out, يعني حتى I only read it on Twitter actually a few days ago. That single antiplatelet versus double antiplatelet has the same outcome, with more complication, more bleeding complication with double antiplatelet for TAVI. So there's no guideline. There's no guideline. There's no evidence for either or. Okay.
Yes. Thank you.
طيب, let me. We'll just run through a few case scenarios, okay? It's not going to be we'll try to make it as an oral exam. Can you see the slide?
Not yet.
Okay.
Yes.
No?
Yes, now I can see.
طيب يلا. يلا هيثم, go ahead.
Okay, so this is a 79-year-old male. He came to the ER diagnosed to have non-ischemia, ankylosing spondylitis, chronic kidney disease, and stage 2, and previous cholecystectomy. No new chest pain, no shortness of breath, palpitation, or syncope. So non-ischemia, okay, with the chronic kidney disease and hypertension.
So
Hello?
the patient was أيوة.
Yeah, تفضل.
So next, you'll usually do history physical exam, obviously. This is his recent lab work. Anemic, his creatinine is 120 milligram per deciliter, and he has normal coagulation profile. So he had NSTEMI. The patient present with NSTEMI. He was taken to the cath lab. This is chest X-ray. This is his cath.
Okay, so
So can you describe the picture that you're seeing?
So this one is actually aortogram. What he's doing, it's taking shot on the aorta. Then I can see the both coronary coming off. The aortogram showing normal, looks like normal size aorta. No sign of dissection or dilatation. No sign of, you can say, calcification from this shot, and it seems he comments يعني I need a full coronary angiogram.
صوتك كان يقطع, ما سمعت.
للاسف عشاني في المستشفى وبستخدم النت هذا.
طيب finding coronary, he has multi-vessel disease as written here, and aorta as seen. Can you describe the aorta?
Okay, this is an aortogram showing actually normal. For me, it is normal aorta. No evidence of dissection, no evidence of dilatation, and I can see the coronary cusps. Actually, the three of them, or at least the two of them. Yes, that's it.
The wall of the aorta.
Haytham,
What do you think of the wall of the aorta?
heavy calcified.
Oh yes. Yes, now it's clear. I think because of the internet I cannot see well.
يمكن يقطع شوي.
Yeah, this is very heavily calcified. Actually, it is like a pipe from here and here, from both sides.
Yeah, okay. So his echo is this.
Okay, so this is a long axis parasternal view showing mildly dilated LA, relatively normal and hypertrophied LV. RV is normal. I can also appreciate maybe some calcification on the aortic valve as well.
Okay.
So this is the same view, but concentrating here on the aortic valve area, I can see like restricted motion opening and closing on the aortic valve. Siniotubular junction seems normal, not dilated. I can see the calcification above the siniotubular junction in the aortic valve as well. Okay, same view. It's showing now a mosaic color flow, which indicate from this view, seems like severe aortic stenosis.
كيف تعرف تقول لنا سيدي؟
طبعا I cannot say that. Actually, I need to measure the area. Sorry, this is wrong. Just there is a mosaic color.
Yeah. في AI شوي.
Yeah, there is also aortic regurgitation. It seems moderate, though, mild to moderate aortic regurgitation.
Yeah.
Okay, this is a CT scan. Okay, severely calcified aorta in the ascending portion and the arch descending, almost porcelain aorta in the ascending level as well, because it's moving fast. Yes, here. And severely calcified aortic annulus.
طيب, what do you want to do for this patient now? خلاص, you have all data, right? Almost 80-year-old male present with NSTEMI, severe aortic stenosis, with a calcified aorta and multi-vessel coronary artery disease.
To start with, just the presence of this severe aortic calcification and his age, of course, I need to assess the frailty, but just because of this too and chronic kidney disease, so this patient, it is not surgical candidate because the risk of a stroke with this calcification is very high to end up with a stroke if I went to CABG plus AVR. So he's a candidate for TAVI plus PCI. I will discuss with the patient this issue. This patient now, actually, he came with non-STEMI. So first of all, I will do PCI for his coronary. Then after 2 weeks time, I will do his TAVI. طبعا before that, this is as a general plan. I need to have the core CT, I mean CT protocol for the aorta, especially in the lower limb with this atherosclerosis. I need to measure the femoral. Now the planning for the TAVI, which is first the CT scan, okay, especially for my axis, which axis that I will go for. What?
في حاجة مهمة نسيت تقولها موجودة في الجايد لاين and it's class 1 indication.
Okay, heart team discussion. So I need to discuss this patient. Sorry, sometimes I speak and move heart team discussion. Okay, طبعا, because even here in our no patient is going for TAVI in our center without discussion with a surgeon, and we are actually a part of TAVI team in King Fahd. So first heart team discussion regarding the patient, what is the proper treatment plan for him. Then after that, we will go to the patient explaining this is our plan. Then we will do pre-procedure investigation in form of according to his comorbidity that he needs طبعا CT for planning, CT core valve for planning, which is CT from the heart until the lower limb for the axis, I mean the femoral especially. Or طبعا alternatively we can do before they just doing shot in the femoral. But for the better planning, especially for implanting the valve, we need the CT. Then the issue with the CT specifically with this patient is his high creatinine, chronic kidney disease. So we need to do hydration for him, all that, preparing him, give him the risk. If everything that, okay, so now this is the CT done. So I have, sorry, okay, the annulus left main height is 9 millimeter, RCA 14 millimeter, sinus is 31, 31, 30, here 20. I think, I didn't recall in the core valve, but I think he can take 23 valve or, but there is a chart, of course, I didn't memorize it. But and there is a specific for each patient, the height, the sinuses of Valsalva diameter, the height of the left main, the height of the RCA, that will technically that I can do TAVI or not. I think I didn't recall, but I think his reading here, I think it is acceptable, but I need to review the chart actually.
There is one number that's concerning.
Left main height 9 millimeter. I think it's supposed to be 12.
10 above.
10 above. Okay.
10 and above for coronary height is يعني fixed number. All valve, all sizes. إذا كان أقل من 10 it's a concern. Okay. Okay. So what do you think of this implant?
It is down. I think it is down in the LVOT.
Low, huh?
Ventricular. Low, sorry. Low, yes. It's in the LV, more down, need to be up. طبعا there is an implanter view that I need, there is a specific view, and where where is the end, the last end of this stent where we're supposed to be. And this is all it must be discussed before doing the study. But from this one, clearly it's low actually.
This is clearly low. So where should it be?
It should be, I think, just طبعا above this one, maybe 2 to 3 millimeter above. So in Corva, this seems to be the Medtronic was just to be just below the nadir, a little bit down. That's it.
أيوة يعني كم مليمتر؟
2 to 3 millimeter.
Okay. This one.
This one, طبعا the view, I don't. Okay, I think it's high. This is high a little bit. Yes.
high. هذا
This is high. Supposed to be a little bit down.
وهذا
Yeah, I think. النت لا حول ولا. Okay.
Hussein, do you see it, Hussein?
Yes, yes. This is, I think, this one is good one. I think so. This one is good one. What do you think, Hussein? Maybe the internet is better in your side, but I think this is better. This is a
this one also high.
Yeah,
high.
It's high. هنا اللي هنا يمكن مو مبين عندك كثير. هنا
النون coronary cusp.
Yeah,
أنا have. اتفضل.
Yeah.
Oh yes, it is high. Yes, now it's clear.
Yeah. So they're both high. So you get the idea. They might show you a picture, high, low, very obvious. يعني they're not going to show you something. I think إذا جاتكم case في الاختبار يعني.
In between.
Yeah, in between. Okay. All right.
And it is 2 millimeter, 2 to 3 صح under the nadir يعني very حاجة بسيطة المفروض.
Yeah, I think the recommended number is between 4 and 2 millimeter, I think.
Okay.
Yeah.
الواحد يبغى يراجعها ما بيسويها كثير ف.
طبعا this is for core valve. For
yes,
for
Sapien different.
For Sapien is different. It's 30-70%. 30% ventricular, 70% aortic.
Okay.
طيب. Hussein, maybe you can take this case.
Okay. So 56 years old female in the stage renal disease and hemodialysis for last 3 years. Had previous CABG 4-5 years ago. Hypertensive, dyslipidemic, type 2 diabetes, AFib and comedine, moderate alcoholic intake, echo report severe MR, main gradient 7, and area 1.5, so it's mixed MR, and referred to you as to assess her mitral valve surgery. Patient NIHA class 3 for last 4 months, no improvement in breathing or dialysis. So I need more history about the frailty and to calculate the STS score. And I need more history about the symptoms. It's class 3 with optimal medical therapy, or she is not optimized?
Yeah, she's optimized and dialysis 3 times a week. She's fairly active. With symptoms started in the last 2 months.
And there is any plan, or she is on the list for transplant?
Yes.
And the list of the transplant. I need to do physical examination for her, assess if there is any history or any defect in the previous stroke or TIA, cardiovascular examination and lower limb examination for edema and peripheral pulse.
So she's morbidly obese. She's moderately obese with يعني grade 1 to 2 pitting edema. She has, you cannot feel her pulses peripherally, but you can feel good femoral pulse. And on cardiovascular exam, you just the only thing that's obvious is the mitral regurg murmur.
Any history of claudication in this patient?
لا.
I will order for her blood work, CBC, and liver and renal profile, coagulation profile, and chest X-ray, ECG, and echo.
Okay, so she's anemic for her chronic disease, hemoglobin around 8.5. Liver function is normal. Renal function is as expected for end-stage renal disease or hemodialysis. And echo already showed the normal ejection fraction, severe MR with mainly posteriorly directed jet, with a mixed picture between MR and MS on dilated atrium.
And chest X-ray normal?
Chest X-ray is normal.
Obviously, this patient is high risk patient. She is end-stage renal disease and hemodialysis, and previous cabbage patient. And her symptoms mainly due to the mitral regurg.
Yeah.
I will discuss this case in the combined meeting and see the as a technical issue if they can do the mitral clip for this patient, and make sure she is optimized medically.
Why mitral clip?
Because she is very high risk for surgery, end-stage renal disease and redo cabbage. If I take her for surgery, her mortality will be high.
Do they do mitral clip for mitral stenosis?
Yes, no.
General rule, no.
Yeah, no. She's not a candidate for mitral clip. عشان كده حطيت لك stenosis يعني.
So in that case, if she accepts the low risk, the high risk, I have to do repeat the coronary angio for her. And I will do ultrasound carotid for her also.
Okay, so can you, from these images here, and I'm not sure if it's obvious for you, do you see anything that's striking for you?
She had severe mitral regurg.
This one.
And have you calcified?
No.
Have you calcified the ايش؟
Annulus.
ايوه. ايش سميه؟
mitral annular calcification.
Yeah,
mitral annular calcification. Yeah. How can you tell from the echo?
It will be thickened and brighter than the adjacent structure.
Oh, okay. What else? What can tell you that this is يعني أكيد calcium and not artifact ولا بس problem with the gain or something?
It looks all calcium, and also in the subvalvular apparatus the cordia looks also calcified.
أيوة. بس في حاجة very يعني diagnostic للكالسيوم في الإيكو.
acoustic shadow حق الكالسيوم.
أيوة للشادو. Just like a mechanical valve. Okay. So هنا this image is very obvious, صح? Okay. So the shadow. Okay. So she had severe, she has mitral annular calcification. Right?
Yes.
Is there anything you want to do to يعني quantify it or measure it or see to have a better and more information about the MAC?
We can do calcium score,
كيف؟
but CT by CT.
CT. Okay. CT no contrast. No need for contrast, صح?
Mhm.
To look at the calcium. Okay, so you did the CT. I don't have the picture, but you have يعني horseshoe calcification around the mitral valve. What are you going to tell the patient?
Posterior and interior. Huh?
Horseshoe. ما anterior usually there is no calcification. كده.
That make her risk is higher.
Yes. Okay, so what are you going to tell the patient?
Taking in consideration end-stage renal disease and redo surgery with heavy calcified mitral annulus, she will be very high risk, and her mortality and morbidity will be high after surgery. So actually, I will be shy away to take this patient to surgery.
Okay, so you're right. She's very high risk for any intervention, but she's not inoperable. So can you tell me what are the options? يعني أنت you're saying surgery.
Yeah, it's she's not for surgery and not for clip. I don't know if it's if my colleague in cardiology department can help me if they can put valve and mitral valve. It's new technology. I don't know if we have it here or not.
Yeah. So what are the options? Those are the options that I want to يعني to know, surgical or interventional option. I would say, what are your surgical options? If you take this patient to the OR, what can you do for her?
I'm not experienced with minimal invasive, but this patient, if one of my colleagues comfortable to do her minimal invasive, that will be good for her to avoid resternotomy for her, or just we do the thoracotomy to avoid resternotomy and high risk of cabbage.
But mitral annular calcification is contraindication for minimal invasive.
Not minimal invasive. I'm sorry, not minimal invasive by per se. It's thoracotomy. Thoracotomy approach.
So these patients, okay, there is a high risk. She's a female and chronic kidney disease with all these calcifications. So the risk of rupture in the AV groove is high. So what I can do, either I can go meticulous debridement of surgically. Now I'm speaking. The option is surgery, meticulous debridement, then patch that area. Then valve, either I can take it. The valve choice intra-annular, so yeah, or supra-annular. With this kind of patient, you can go supra-annular, but keep in mind, in the supra-annular position, you will have higher gradient with those kind of patient. There is a series. To start with, I'm not expert. I know what is what's to be done, but I will ask for the help of my senior consultant. Either he will do the case and I will shy away. I will not do it. And تفضل.
So your option is mitral annular decalcification, reconstruction of the mitral annulus,
and
the mitral annulus, and mitral valve replacement, right? So
yes,
you have to know the technique for mitral annular decalcification.
This is one.
Hey.
Yes.
You have to know the technique and what are the options to reconstruct it.
So there is either sometimes you can take the suture in the calcium itself, but this will increase the risk of dehiscence. The technique, it's need, you just be meticulous with the debridement, and just at the end you apply the patch on it.
Where
طبعاً
to where?
Sometimes you will end up with for example, you will end up with a bunch of posterior mitral leaflet that is not, it's gone because of the decalcification. So at that area you need to cover it.
Yeah. So usually when you decalcify posterior mitral valve annular calcification from commissure to commissure, you have to apply a very large patch, commissure to commissure, yes, from the ventricular aspect to the atrium, and then you start putting your suture. So this, you reconstruct the whole AV junction, right? The whole atrioventricular junction posterior, yes, from commissure to commissure. The other option is that if the calcification is not as extensive, you can just do atrial advancement. Okay, so when you decalcify the annulus, the gap between the atrium and the ventricle, you can just put stitches in the atrium and just advance it to the ventricle. So those are the technical option. The other option is just taking pledgeted suture from the ventricle to the atrium and just bring them together. So you have to read about this. You have to know the option because you might be facing this. You might open and find the calcification intraoperatively. You didn't know about it pre-op, صح? Okay.
So what's your approach, Dr. Fahd? You will open her sternotomy or thoracotomy?
I will do sternotomy. Depends if the valve. It depends on the grafts, but I'm more comfortable doing complex mitral valve replacement like this one, okay, through sternotomy, because you have better access to the calcium. You're closer to the valve. Through thoracotomy, I think it will be difficult. Having said that, now the other option that I want to talk to you about is actually putting a transcatheter valve in the calcium.
Yeah.
Okay. This can be done either on pump on an arrested heart. You open the atrium. You decalcify. You resect the leaflets. Okay, and then implant a balloon expandable valve, the sapien valve. And then you can also suture it. You can add suture to fill in the gaps between the valve itself and the annulus and the native annulus, to prevent paravalvular leak. Okay, this option is on the table. You can mention it. Obviously, you're not going to do it alone in the exam. There are pitfalls for it. It's going to be a hard team discussion, but this is an option.
We cannot do it transcutaneous.
Yes, the last option is transcutaneous valve in MAC. It's called transcutaneous or transcatheter valve in MAC. There's more experience with valve in valve, mitral valve in valve, so degenerative mitral valve prostheses. But valve in MAC as well is an option. The outcome of this is the outcome of any of these options is actually very poor.
Yeah.
Okay. To summarize, all these procedure have very high mortality. سواء surgical ولا transcatheter has a very high mortality and morbidity risk. But you have to know the option for those cases. Okay, severe MAC, how to deal with it, what are the options. There are papers online. I'm sure if I can I'll find one and send it out to you. Technical for implanting valve on pump and what are the pitfalls for it. one major thing for valve in MAC during transcatheter one, يعني compared to an open one, is that you have a very long anterior valve leaflet, okay? Anterior mitral valve. شوف هذه الليفلت. Okay. Can you imagine putting a prosthesis here? Okay. If you imagine putting prosthesis here, هذه الليفلت فين حتروح؟
حتسوي
البي
حتسكر الفي. But this is the Achilles heel for transcatheter mitral valve implantation now is actually this, okay? LVOT obstruction or LVOT gradient. So that's why with surgery you can resect the leaflet, وبعدين you implant the prosthesis. With the, something to think about. Yeah. There are other transcatheter technology to deal with it. To be honest, to deal with the leaflet, you don't have to know all these details. You just have to know that there are options. Those patients are very high risk. You discuss with the patients, obviously, explain to the high risk of intervention, and have a senior help. Okay, I think هذا البوينت كانت من الكيس. Now عندنا aortic dissection. I prepared slides to be honest yesterday لأنه كان المفروض دكتور تركي بس اعتذر. وعندي case also a case to go through for aortic